Hi, I'm Sue McCarthy Robinson, and for this session, we're going to be speaking about caring for the mental health needs of special populations in primary care. We're going to cover 6 different populations. So let's get started. So the first group is the elderly and geriatric. So covering the epidemiology, depression amongst the elderly is prevalent. This estimates suggesting that up to 20% of adults aged 65 and older experience depressive symptoms. This population may be at an increased risk due to factors such as chronic health conditions, social isolation, bereavement, and cognitive decline. The economic costs, depression in the elderly imposes substantial economic burdens, including direct health care costs for treatment and management, as well as indirect costs related to lost productivity, caregiver burden, and increased healthcare utilization for comorbidity conditions. Estimates indicate that economic burden of depression in older adults amounts to billions of dollars annually, highlighting the importance of effective prevention and treatment strategies. Elderly geriatric diagnosis and criteria. The diagnosis of geriatric depression is based on the same criteria used for other adults, but is essential to consider the age-related factors and potential comorbidities. Some common symptoms of depression in older adults may include depressed mood most of the day, nearly every day, marked diminished interest or pleasure in activities, significant weight loss or gain, or appetite disturbance, insomnia or hypersomnia, psychomotor agitation or retardation, fatigue or loss of energy, feelings of worthlessness or excessive guilt, diminished ability to think or concentrate or indecisiveness, recurrent thoughts of death, suicidal ideation, or suicide attempts. The elderly geriatric treatment plan. We'll look at the pharmacological interventions. SSRIs, they'll increase the serotonin levels in the brain. Contraindications could be history of hyponatremia, bleeding disorders. SNRIs, it elevates serotonin and norepinephrine levels. Contraindication, uncontrolled hypertension, severe liver disease. Side effects, increased blood pressure, urinary retention. TCAs, dynamics, block reuptake of serotonin and norepinephrine. Contraindications, cardiac conduction abnormalities, glaucoma. Side effects, dry mouth, constipation, sedation. Collaborative interventions, regular medical monitoring would be essential, vital signs, medication adherence, nutritional support, ensure adequate intake of nutrients, physical activity, encourage gentle exercises like walking, social support, facilitate involvement in support groups. The psychotherapeutic options, cognitive behavioral therapy, individual versus group, dynamics change negative thought patterns and behaviors and improve relationships. Supportive therapy, provide empathetic listening and emotional support. Reminiscent therapy, utilize memories to foster emotional connections. The second group we'll look at perinatal and lactation, the epidemiology. The perinatal depression, including both antenatal and postpartum depression, affects approximately 10 to 15% of women during pregnancy and up to 20% in postpartum period. Lactation depression, which occurs during breastfeeding, is less studied but is estimated to affect around 10 to 15 of postpartum women. These conditions can impact maternal and infant health outcomes if left untreated. Economic costs. These economic costs of perinatal and lactation depression include healthcare expenses associated with treatment, increased utilization of medical services, and lost productivity due to maternal morbidity and impaired functioning. Additionally, there are societal costs related to adverse child development outcomes and potential long-term consequences for maternal mental health and well-being. Estimates suggest that perinatal depression costs billions of dollars annually in the healthcare expenditures and productivity losses, underscoring the importance of early detection and intervention to mitigate these economic burdens. Covering the perinatal lactation diagnosis and criteria. The criteria falls under the major depressive disorder with a specifier for peripartum onset, which encompasses the period of pregnancy and 4 weeks following childbirth. Here's a summary of the diagnostic criteria. 5 or more of the following symptoms have been present during the same 2-week period and represent a change from previous functioning. At least one of the symptoms is either 1, depressed mood, or 2, loss of interest or pleasure. So the depressed mood most of the day, nearly every day, marked diminished interest in with pleasure and activities, significant weight loss or gain or appetite disturbance, insomnia or hypersomnia, psychomotor agitation or retardation, fatigue or loss of energy, feelings of worthlessness or excessive guilt, diminished ability to think or concentrate or indecisiveness, recurrent thoughts of suicide, death, or suicide attempts. Perinatal lactation treatment plan. So pharmacologically, SSRIs increase serotonin levels in the brain, some contraindications, history of hyponatremia, bleeding disorders, side effects, nausea, insomnia, sexual dysfunction. Some considerations, generally considered safe during pregnancy and lactation with close monitoring, potential for neonatal withdrawal symptoms. SNRIs elevate the serotonin and norepinephrine levels, contraindication, uncontrolled hypertension, severe liver disease, side effects, increased blood pressure, urinary retention. Perinatal lactation considerations used cautiously during pregnancy and lactation. Monitor for potential neonatal complications. TCAs. It blocks the reuptake of serotonin and norepinephrine. Contraindications, cardiac conduction abnormalities, glaucoma, some side effects, dry mouth, constipation, sedation. Perinatal lactation considerations, avoid during pregnancy due to potential risks, can be used cautiously during lactation with close monitoring for infant side effects. Collaborative interventions, regular medical monitoring, so vital signs, medication adherence, nutritional support, physical activity, some gentle exercises like walking, social support, facilitate involvement in support groups, psychotherapeutic options, cognitive behavioral therapy, whether it's individual or group. This will change the negative thought patterns and behaviors and improve relationships. Supportive therapy provides that empathetic listening and emotional support. Reminiscence therapy utilizes memories to foster emotional connections. Next group that we'll cover is pediatric and adolescents. So the epidemiology. This group's depression is prevalent mental health condition, which estimates indicating that around 3 to 5% of children and adolescents suffer from depression at any given time. Furthermore, up to 20% of adolescents may increase in a depressive episode by the age of 18. These rates may vary depending on factors such as age, gender, and socioeconomic status. The economic costs of the pediatric and adolescent depression encompass direct healthcare expenditures for diagnosis, treatment, and management, as well as indirect costs associated with impaired academic performance, increased risk of substance abuse, juvenile delinquency, and future psychiatric morbidity. Additionally, there are societal costs related to reduced productivity and the burden on families and caregivers. Collectively, these economic burdens emphasize the need for early intervention and comprehensive mental health services for children and adolescents with depression. Pediatric and adolescent diagnosis and criteria. It is the major depressive disorder in children and adolescents, considering age-appropriate manifestations of depressive symptoms. The symptom duration. Assess the presence of depressive symptoms lasting at least 2 weeks, including persistent sadness, irritability, loss of interest or pleasure, changes in appetite or sleep, fatigue, feelings of worthlessness or guilt, difficulty concentrating, and thoughts of death or suicide. Functional impairment. Evaluate the impact of depressive symptoms on social, academic, and familial functioning, recognizing the significant disruption it may cause in daily activities and relationships. Rule out other conditions, such as substance abuse and other mental health disorders that may mimic or exacerbate depressive symptoms, ensuring accurate diagnosis and appropriate treatment planning. The severity and specifiers. Determine the severity of the depression based on the symptoms, intensity, and impairment level, and consider additional specifiers such as psychotic features, seasonal pattern, anxious distress, to further characterize the representation and guide treatment decisions. Pediatric adolescent treatment plan. So you want to get a comprehensive assessment, conduct a thorough evaluation of the child or adolescent's depressive symptoms, medical history, family dynamics, and psychosocial context to inform treatment planning. Psychotherapy. You offer evidence-based psychotherapeutic interventions such as the CBT or interpersonal or family group sessions to address negative thoughts, patterns, improving coping skills, and strengthen the social support network. Medication management. Consider antidepressant medications such as your SSRIs in combination with psychotherapy for moderate to severe depression, carefully weighing potential benefits and risks based on individual needs and preferences. Supportive environment. Create a supportive and nurturing environment at home, school, and within the community, emphasizing open communication, validation of feelings, and encouragement of healthy lifestyle habits. The collaborative care. Coordinate care amongst mental health professionals, pediatricians, school counselors, and other relevant stakeholders to ensure integrated and holistic treatment, including regular monitoring of symptoms, medication adherence, and response to interventions. The family involvement. Involving the parents and caregivers in treatment planning and implementation, providing education about depression, teaching effective parental strategies, and fostering family resilience and communication to support the child or adolescent's recovery journey. The next group is the LGBTQ group. These individuals experience higher rates of depression compared to the heterosexual and cisgender peers to factors like discrimination and lack of social support, with transgender and gender non-conforming individuals facing particular elevated risk. The economic costs. This economic burden of the LGBTQ depression encompasses healthcare expenses, reduced workplace productivity, and limited career opportunities due to discrimination, underscoring the importance of addressing mental health disparities to enhance individual well-being and economic outcomes. LGBTQ diagnosis and criteria. To diagnose the depression with these individuals, clinicians refer to the DSM-5 criteria, which include symptoms such as persistent sadness, loss of interest in activities, changes in appetite or weight, sleep disturbances, fatigue, feelings of worthlessness or guilt, difficulty concentrating, and suicidal ideation or behavior. The duration and impairment. These symptoms must persist for at least 2 weeks and cause significant impairment in social, occupational, other important areas of functioning to meet the criteria for a diagnosis of depression. Consideration of context. Clinicians must consider the unique stresses and challenges faced by these groups, such as minority stress, discrimination, and lack of social support, which may contribute to the development and exacerbation of depressive symptoms. Differential diagnosis. It is essential to differentiate depression from other mental health conditions and medical disorders that may present with similar symptoms, including adjustment disorder, bipolar disorder, or substance use disorder, and medical conditions such as hypothyroidism. Cultural competence. Clinicians should approach the assessment and treatment of depression in LGBTQ individuals with cultural competence, understanding the impact of social attitudes, stigma, and discrimination on mental health outcomes, and tailoring interventions accordingly. The LGBTQ treatment plan. You begin with a thorough assessment of the individual's mental health history, current symptoms, and social context, referencing their LGBTQ identity and any unique stressors or challenges they may face. Evidence-based interventions. Implement evidence-based treatments for depression such as cognitive behavioral therapy, interpersonal therapy, pharmacotherapy, tailored to the individual needs and preferences. Address minority stress. Incorporate strategies to reduce these stressors, including discrimination and lack of social support, through interventions aimed at building resilience, fostering social connections within the LGBTQ communities, and challenging internalized stigma. Supportive environment. Create a supportive and affirming therapeutic environment where the individual feels safe to explore their identity, express their emotions, and discuss their experiences without fear of judgment or rejection. The collaborative care. You want to collaborate with your healthcare providers, the LGBTQ affirming organizations, and support networks to provide holistic care addressing both mental health needs and any additional concerns related to the individual's LGBTQ identity, such as an access to affirming healthcare services or legal protection. Our next group is the immigrant migrant workers. The epidemiology. These workers face increased risks of occupational health hazards, mental health issues, and infectious diseases due to factors such as language barriers, limited access to health care, precarious working conditions, and social isolation. The economic burden of health issues among immigrant and migrant workers encompasses health care expenses, lost productivity due to illness or injury, and costs associated with workplace safety violations, highlighting the need for improved access to health care and labor protections to mitigate these costs and promote workforce well-being. Diagnosis and criteria for the immigrant and migrant workers. Risk factors assessment. So they evaluate the stressors related to their migration experience, such as acculturation, stress, language barriers, discrimination, social isolation, which may contribute to mental health disorders like depression, anxiety, or post-traumatic stress disorder. Occupational health hazards. Screen for occupational health hazards and work-related injuries or illnesses, considering factors such as exposure to toxic substances, unsafe working conditions, physical strain, and inadequate access to healthcare services. The cultural considerations recognize the influence of the cultural factors on the expression and interpretation of symptoms, ensuring culturally competent assessment and treatment approaches that respect the individual's cultural beliefs, values, and experiences. Trauma assessment. Assess past traumas, including those related to the migration, such as displacement, violence, or persecution, and consider the impact of trauma on mental health and well-being. Collaborative care planning. Develop a collaborative care plan involving mental health, professional, occupational health specialists, social workers, and cultural liaisons to address the unique needs of the immigrant migrant workers, providing culturally sensitive interventions, assess to healthcare services, access to health services, and support for navigating work-related challenges. The Immigrant Migrant Workers Treatment Plan. Culturally competent therapy offers culturally sensitive therapy, incorporating elements of individuals' cultural background and beliefs to facilitate trust and engagement in treatment, while addressing mental health issues such as depression, anxiety, or trauma-related work disorders. Workplace interventions. Implement these interventions so they aim at improving safety standards, providing training on occupational hazards, and advocating for policies that protect the health and rights of that immigrant migrant worker, reducing the risk of work-related injuries and illnesses. Access to healthcare. Ensure that there is access to affordable and culturally competent healthcare services, including mental health care, preventative screenings, and treatment for chronic conditions, addressing barriers such as language, documentation status, and lack of health insurance. The social support networks facilitate connections to social support within the immigrant communities, peer support groups, and community organizations, fostering a sense of belonging and resilience while addressing social isolation and stressors related to migration. Policy advocacy. Advocacy for policy changes at local, national, international levels to improve labor rights, access to health care, and social protections for the immigrant migrant workers, addressing systemic issues that contribute to health care disparities and economic vulnerabilities. The next group is the ethnic minority groups. So the epidemiology. This group often experiences higher rates of depression compared to the majority population, influenced by factors such as discrimination, socioeconomic disparities, acculturative stress, and limited access to culturally competent mental health care services. Economic costs. Depression in ethnic minority groups incur significant economic costs due to healthcare expenses, lost productivity, and reduced quality of life, highlighting the need for targeted interventions to address disparities and promote that mental health equity. The diagnosis and criteria for the ethnic minority groups. Culturally expression of symptoms. So the DSM-5 recognizes that presentation of depression may vary across ethnic minority groups due to cultural factors. Symptoms such as somatic complaints, interpersonal difficulties, or spiritual distress may be more prominent than typical affective symptoms. The diagnosis criteria considers acknowledging the importance of considering the cultural context when applying diagnosis criteria for depression in ethnic minority groups. Clinicians are encouraged to be sensitive to cultural variations in symptomology and impairment levels. The acculturation and identity. The DSM-5 underscores the impact of the manifestation and perception of depressive symptoms in ethnic minority populations. Individuals navigating between their cultural heritage and mainstream culture may experience unique stressors contributing to the depression. The access to care and help-seeking behavior. The DSM-5 recognizes disparities in access to mental health services among ethnic minority groups, which can affect the recognition and treatment of depression. Factors such as language barriers, stigma, and distrust of healthcare systems may hinder help-seeking behavior. The culturally competent assessment and treatment. The DSM-5 emphasizes the importance of culturally competent assessment and treatment approaches for depression in ethnic minority populations. These include considering the cultural beliefs, practices, and community resources in developing personalized treatment plans to address the diverse needs of these individuals. The treatment plan for the ethnic minority groups. Culturally tailored interventions is desirable. Develop these treatment plans that incorporate culturally relevant therapies, such as culturally adapted cognitive behavioral therapy or narrative therapy, to address the unique experiences and beliefs of ethnic minority individuals with depression. The community engagement and support. Utilize community resources and support networks to enhance treatment outcomes. Collaborate with community leaders, religious institutions, and cultural and organizations to provide culturally sensitive psychoeducation, support groups, and outreach programs. Language and communication considerations. You ensure effective communication by providing language appropriate materials and employing interpreters when necessary. Facilitate open dialogue about cultural perspectives on mental health and treatments to foster trust and engagement in therapy. Family and social support integration. Involve the family members and other social supports in treatment process, recognizing their important role in recovery of the individuals from ethnic minority backgrounds. Incorporate family therapy or involve family members in psychoeducation sessions to address familiar dynamics and support systems. Addressing structural barriers. Advocate for policies and initiatives that address structural barriers to mental health care access, such as improving insurance coverage, increasing diversity in the mental health workforce, and reducing stigma within healthcare systems. Collaborate with the community stakeholders and policymakers to promote equity and inclusivity in mental health services. Thank you.